we just take a collective breath?
Yeah.
Can we? All right. Thank you for that. Over the years, I have spoken at countless events like these, and I just want to express my gratitude to each and every one of you who came into this field or are coming into this field to do this life-saving work. We do not come into this field because we want to buy a small island off of Madagascar. We come into this field because we care, but also it's personal on some level. And I'm seeing your heads. So, your head's nodding. So I just want to take a moment and ask, how many of us are connected to either someone who uses drugs or someone who's in recovery, or ourselves are in recovery? I want you to look around the room and see your allies, and see your family, and see your community, and make those connections. It could be a lonely road to have this this condition, and with what's going on, which I'll talk a little bit about, but I know that y'all know because y'all are doing the work and you're here, that we are in the midst of not a public health crisis, but a public health emergency. And it's going to take all of our collective will and our care, but also we need each other. We can't do it alone. So I want to just thank you all for the courage, the tenacity, and the strength that it takes to do this work. Thank you for being here. So, okay. So my name is Stephanie Campbell. I have a few letters after my name, but that's not what I'm most proud of. What I'm most proud of is that in 1989, when I was living in abandoned buildings as a sex worker, as a queer sex worker, had overdosed I don't know how many times. We didn't have naloxone then. But we had our ways of getting ourselves, keeping each other alive. Someone pulled me out of the gutter and gave me the message of hope. And I come from a long legacy of people who use drugs. And why do people use drugs? People use drugs because they're hurting. They're hurting. And people, by the way, have been using drugs ever since we first figured out how to crush grapes. Right? Oh, this feels good. I'll do a little bit more of this. Right? There's a whole industry about that. But I was marinated in alcohol in my mother's womb. And so I came to this planet very well equipped and looking forward to applying the tools that I had been given in utero. So I'm going to talk today about something that, and I also, the government folks, can I see the government folks in here? God bless you all. It's a thankless job, isn't it? You get all the, can I curse here? You get all the shit, but very little of the thank yous. Having been a person in recovery from working in government, I salute you. But I'm going to talk about the intersection of, and we talk a lot now, the intersectionality is a big buzzword now, but I'm going to talk about the intersection of advocacy and public health that's happening in New York State, that I and lots of people that came before me and taught me what to do, are creating these partnerships. The most effective partnerships, and I also teach at NYU, although I'm on sabbatical right now, I teach SUD policy. And one of the things I say to my students, the most effective way to make good policy is when you got the decision makers and the folks on the ground talking to each other, right? I love the head nodding that's going on here. That is effective. You've got to have top up and bottom down, right? You've got to have these folks talking to each other. And you have to have these folks talking to each other in a mutually respectful way. We do very different things, and I'll talk a little bit about some of my own, metamorphosis into this world. But we're in very different worlds. But when that synchronicity happens, the world changes. And I guess I have to use this. There we go. So there's a long legacy of activism in public health, and where I cut my teeth was, I told you about that kid back in 1989 who got pulled out of the gutter and brought into a community of people who were a day at a time not using drugs, or a day at a time, right? Because I believe recovery is any positive change. So a day at a time, not everybody in that room was not using drugs, they're abstinent, right? There were some people that were abstinent, had long-term recovery, were thriving in their lives. And other folks that were in that room were folks like me, little queer kids who came because there was a jelly donut available. And at that time in my life, I couldn't eat a lot of solid food because I'd been using real hard and stuff that and I was sick a lot, and I couldn't go for a lot of time without using. And so those folks in that room made space for me, and they said, honey, you always knew you were going to get some a little bit, They said, honey, you go in that room, in the bathroom, you use those drugs, but you come back here, and you hang out with us, and you let us love you until you learn how to love yourself. Right? Because I was a 20-year-old sex worker. There wasn't a whole lot of love that I had for myself. But there were these people that looked at me, not like the people when I went to emergency rooms to cop drugs, because by the way, I knew where to cop drugs in emergency departments all over the city of New York. And some hospitals you can get the real good stuff, and some they had caught on to the deal, and they knew people like me were looking for stuff, and so they wouldn't give me my stuff, and I'd get real mad. But these people in this room said to me, let us love you until you learn how to love yourself. That was the first experience I had with harm reduction, and that was in a room full of alcoholics and drug addicts who were recovering a day at a time, right? And that was community. My friend talked about an email that I sent him. I didn't even remember that email, where I talk about the antidote to this public health crisis is not naloxone, although that helps keep people alive. But it's community and connection. It's a place where people like me can meet with each other in safety and have love and have people who look at us like we're human beings. Because at that time in my life, I had stopped being a human being. And you were either a customer or a connection, for me to get what I thought I needed, right? Which is to get the hell off this planet as quickly as possible, right? And so, and isn't it interesting that the same folks that are overdosing today and dying are the same folks, back in 1989 when I came in, that ACT UP, which was a community of people, right, queer folk, who were dying. A lot of gay men were dying from a big disease with a little name, right, as our friend Prince used to say. And so we learned that, and by the way, we would show up at hospitals with this disease, and the nurses would leave our food outside of our rooms because they didn't want to catch that disease, right? And they were barring us from coming into their emergency departments because they were afraid we would get them sick. So we learned that in order for us, that we had to speak truth to power. We had to name the thing. And we also had to build relationships with people in government. And we had to build relationships with the officials in public health, right? Because they wanted to help. They were trying, but they didn't know necessarily what the tools were. And so it was that bottom-up approach and that top-down. And we had people that were willing to say, okay, I don't know what I don't know, but help me learn. And that's the value of lived and living experience, is that when when advocates are able to collaborate with government and public health officials. And we're doing that now. You know, we're getting the FDA to approve all forms of naloxone, right? So that we can get, naloxone out to the communities in terms of what they need. Naive drug users may need a different dose of naloxone, whereas people who are using drugs, who built up that tolerance, that higher dose of naloxone may be too much, may kick them into, intense withdrawal. And we don't, so we gotta, work with the folks that are doing the work. And I so appreciate, the folks that I heard in upstairs, that Tim and the other person that was speaking, talking about, the value of engaging harm reduction. But we were doing harm reduction during the HIV and AIDS epidemic. And we taught the people the doctors how to, that they didn't have to treat our people like they were pariahs, but they could engage in compassionate care. I had I don't have the t-shirt anymore, it got lost along the way, but I remember when I got my Silence Equals Death t-shirt. And that pink triangle, by the way, for those of you who are aware of the queer movement, the pink triangle came from what the Nazis used to do to queers back in the day. And it was what the Nazis put on people who were deemed deviant, homosexuals. And so we incorporated that triangle, and we said, we can't keep silent anymore, because to keep silent means that more people will die. And I'm seeing this happen now with people who are in recovery, or who are still using drugs, who are getting up and speaking out. They're saying, we're going to be silent no more. For the family members who are standing up, because there's a lot of shame and stigma that the families are feeling. The families are hurting, and they don't get a whole lot of treatment. And so God bless groups like Al-Anon and the treatment providers who are supporting the family members. I've been to too many funerals where the family members of their loved ones who are deceased sit in the back room and they hang their heads in shame. Because they think that they could have done more. So we got to love up on those folks. We got to let them know that it affects everyone, not just the person. I'm a crier. I hope that's okay. And I hope I keep crying, because a lot of us are having to shut down because it hurts too much. And we become kind of immune. In New York, y'all here in New Jersey are doing some good stuff. Y'all are doing some good stuff. But in New York, 10% increases every single year. I was at a press conference a few days ago, and I talked to a woman who 10 years ago we were advocating, and she carries around a picture of her son. And she said, "Sesame, how much longer are we going to have to do this?" And I said, "I don't know, baby. But let's hug up on each other and let's give each other some strength. Because the work is hard." The work is hard. So, I shouldn't have worn mascara today. I'd be crying in front of y'all. So, in New York, we're still seeing 10% increases, and I know that you guys have seen the numbers, and in 2022, we saw 111,000 that we know of, right? And I think these numbers are vastly underreported. I think there's a lot more people dying than are even being reported, right? So I sit on the steering committee at SAMHSA, CDC, and NONDCP for harm reduction, and we just put a document together on guiding principles for harm reduction. And I'm really hoping that what we're going to see happen is that we're just going to normalize talking about this. I love what Tim was saying. Where's Tim? Did Tim go? Tim's gone. I'm going to track Tim down. But Tim was talking about, just this. We're trying to replicate this in New York, where y'all have, first responders that can give buprenorphine. That's so great. And in the hospitals. And before COVID, we were able to do that in New York. But things got a little, real weird during COVID. And I think the other thing I want to put a plug in, we've been talking about opioids, and I understand. We need to be talking about it. But let's not forget about alcohol. Because let me tell you something. In New York, we're losing 18 people a day from opioid that we know of, right? Opioid overdoses. We're losing 17 to alcohol. So we're losing 20,075 people, again unreported, New Yorkers, last year that died from preventable overdoses and addiction and alcohol-related issues. And there are communities, and the BIPOC community, alcohol, huge killer. So we got to be able to get folks the support and the care that they need. I don't need to tell you, I talked a little bit about this, the rippling effect that overdose has and addiction-related deaths have on families and communities. We're losing a generation of people. We're losing a generation. And so we got our work cut out. Y'all probably know about the overdose risk factors. I want to tell you a little story. So, I was on the train. I was going down to New York. I was going to this, very fancy gala. I had my schnazzy outfit on. And there was a guy who was sitting on the train, and he looked like he was on fire. I know how to spot our people. And nobody was sitting near him. So I was wearing heels, which are not my specialty, but I was like, I'm going to sit down next to this guy. And we started a conversation, and he told me that he had just gotten out of prison. Just gotten out of prison. And I identified myself as a person in recovery. And he said, well, I'm going to be honest with you. He said, I'm going down to New York. He'd been in prison for 8 years at this point, and he had been in prison multiple times. And he said, I'm going to get me a lady and a hotel, and I'm going to get myself some cocaine, and I'm going to have a good time tonight. And I said, brother, no judgment on my part. You deserve to have whatever you need, because you've been high and dry for a while now. I said, but the drugs are different now. They're different. They're not the same drugs that were there when you went behind the wall. And we ended up having this beautiful conversation, and I said, would you be willing if I gave you the number of a friend of mine in Massachusetts? By the way, when I'm not traveling, and I travel a lot, but when I'm not traveling, there's a 7 a.m. morning meeting that I go to in Pittsfield, Massachusetts at a recovery center. And I get the message of hope, and I get my medicine from these amazing people. And one of the guys that is in this meeting is a recovery coach for folks that are coming out of carceral settings. So I said to this guy on the train, I said, would you mind if I hooked you up with this friend of mine? And he said, all right. And I said, and I hope you call this guy. I said, but you know what? Whatever you do, be careful tonight, because it's a different ball game now. And I gave him my number too. And I think at the end of the conversation, he's like, hey, would you like to join me? And I said, no, brother, it's not like that tonight. But you be well, be safe. Well, it turns out that he called that guy. He called my friend Chris. And they got connected. And this guy is now in recovery. Not my doing. But this is the way it works, right? People with lived and living experience. A friend of mine said in the beginning it was one alcoholic, one addict down in the dirt helping another, and that's where it started, and that's where it'll end, baby. And I was like, what the hell, what is he talking about, right? But folks with lived experience, and for those of you who don't have lived experience, that's okay. We're glad to have you. But use the folks with lived experience. Don't be afraid of those folks. Sometimes they can be a little lively, you know. Sometimes they can cry a little bit, as you can see. But they can help, they can help you do the work. And vice versa, you've got some things to teach them. Anyway, those folks coming out of carceral settings, and there's a lot of work that's being done, because those are the folks that are highest at risk for overdose. Those are the folks that we're seeing in New York City and other places that are overdosing in those high numbers. I'm friends with, I don't know if any of you have heard of Truth Farm, but Alexis Plus is a friend of mine, and every year we go to DC and we put tombstones out, and we talk about the lives, and we took something out of the playbook of the HIV movement, right, where there was that big quilt that we did back in 1985, I think it was. When we went to DC and we unveiled the AIDS quilt, and so we're being very visible now, and stay tuned for something that may be happening in New York soon. Wink, wink, nudge, nudge, because we got to wake some folks up. So we need to take a multi-pronged approach. There's no one-size-fits-all, and traditionally there has been that approach. It's either this or that. And by the way. I speak as a person who is abstinent today, right? It took me a long time to get to that place, but that doesn't make me any better than anybody else who's still using, right? And I think those of us in sustained recovery, we need to atone for some of the arrogance that we've had in the past, where we've kind of conducted ourselves in that space. And we've been paraded out to be the examples of recovery. When people hear that I went to Columbia University and I went to NYU and I did this and I did that, and I went to, right? Oh, look at Stephanie Campbell. Isn't she a model of recovery? Well, that's not, as I said to you, that's not the thing that, for me, that identifies me as an expert. What identifies me as an expert is that I've paid dearly for this seat, as we say. And I've been able to, combine my education with my lived experience to share with folks and to facilitate a conversation. But there are many leaders and many people who are much wiser than I am who are doing this work, and we need to listen to those folks. But one of the things that we're trying to do in New York is we're calling on the governor and the legislature to issue a public health emergency. We need to get all tools in the toolbox. There's not just a one-size-fits-all for diabetes or cancer treatment. We need to have all the tools in the toolbox. And that means we need to get the medication out into the community. We need to make it accessible, and we need to relax some of those regulations, which, by the way, our friends at SAMHSA have recently done in relaxing some of the methadone rules that had prevented providers from being able to give these life-saving medications. And then I want to say a word for the recovery centers. During COVID, I was in government, and I was the director for the first in the nation Ombudsman Office, which I'll talk a little bit about. But when the treatment centers were shut down, and when people couldn't be face-to-face, it was the peers in the recovery centers that were going to people's houses, bringing them a cup of coffee and giving them hope and keeping them engaged. It was the peers that were doing this work, and that's where it goes back where I said, I was told in the beginning it was one alcoholic, one addict down in the dirt helping another. When all systems shut down, it was the folks in recovery, it was the folks with lived experience and living experience who were able to stay connected to the people who were highest at risk for dying. So much respect for those folks. And then we need to, the fourth prong, we need to get people treatment when they need it, on demand. Right now, not tomorrow, not 12 hours from now, not 2 weeks from now, not 6 months from now, right now. My brother from another mother, Rob Kent, and I are doing national work right now on drug policy, and his beautiful mug is up here. But he's been talking a lot about we've got to have a public health emergency issued. There's been a number of states that have done this. It's been very successful. You know, we've been in conversations with the governor saying, listen, you know, what can happen when you relax, when you issue a public health emergency, you can, you know, we can get around some of, and the folks in government know how challenging it can be to get money out the door. It's a wonderful, and you want to get that money out the door, but you're, you know, you're kept from doing that because of some significant regulations which prevent you from doing that. And that's what happened, by the way, during COVID. Some amazing things happened during COVID because we were able to, you know, issue regulatory reform and get stuff, you know, get that relief out, get that money out quickly. I just talked a little bit about this, so I'm not going to go into this. The second problem, we need to get access to all forms of naloxone. Now, here's the thing. There's been the company Emergent that does Narcan has thank God that they've been able to get those 4 milligram doses out to the community. And certainly in New York, you know, Matters is doing a lot with them. Shout out to Matters. When they were in Buffalo, you know, they started this incredible, you know, in real time getting medication out to folks and getting naloxone out. But because of the fentanyl analogs, and because now the people who are dying, very high numbers of folks in BIPOC communities that have not in the past, and it was talked about in the other keynote, they were not given prescription drugs, right? So, you know, it looked for a time that they were, you know, not being impacted as much as, you know, suburban moms and kids and, you know, Caucasians in communities where they've had access to opioids. But what's happening now is that the entire drug supply has been contaminated with fentanyl. There is no heroin out there anymore. So it's fentanyl. And now, of course, with Trank is in it as well. So we need to be able to have, you know, all forms of FDA-approved naloxone. That includes the, you know, the 2 milligrams and the 8 milligrams. 8 milligrams, we've seen some success, some of the studies with naive drug users and folks that, you know, aren't aware that the fentanyl is in their drug supply and they're, you know, overdosing. But, you know, 2 milligrams also. Here's the thing. Communities know what they need. So let's listen to the communities. What a novel idea. Let's hear from them what it is that they need, and then let's give them the tools that they need to do that. I mentioned certifying recovery community outreach centers. Right now in New York State, and I don't know how it is in New Jersey, I suspect y'all are grant run, right? So you've got your tin cup out, right, every year, hoping and praying that money will go into that tin cup, right? We need to certify recovery, we need to certify peers to bill out of those recovery centers so that those billable hours can be sustainable and that the recovery centers can you know, continue. In New York, we do that with the treatment programs. We have deficit-funded treatment programs. I worked in Oasis every single year. If you don't make enough money, we make sure that you have the funds that you need to sustain. We need to do the same thing with recovery community centers. And then that fourth prong, I want to talk about this for a minute, which is treatment on demand. How am I doing for time? I'm good, okay. So years ago, when I was at Friends of Recovery New York and I was the executive director, I'd get phone calls after hour and on the weekends, and I'd usually from parents who were absolutely petrified that their child was going to die. And I would usually get a phone call from an emergency room, and that family member would say they're going to discharge our loved one and they don't have anything. You know, there's no treatment center that's open right now. It's Friday night, it's, you know, 11 o'clock at night. And so, and part of that was because they had to get a prior authorization, right? When you have a heart attack, do you need a prior authorization to go get treated for your heart attack? No. But our people were being denied their insurance benefits, and they were going out to the parking lot and they were overdosing and they were dying. They'd go home and they'd overdose and they'd die in their beds. And so I was brought in to get this program off the ground called CHAMP, Community Access to Mental Health and Substance Use Addiction Project, to get people access to their insurance benefits in real time. So there's this telephone number you call, and then of course people had my number, so they would call me on. I used to have my phone on 24/7. The health and wellness piece for me went right out the window. Do not do that, please. For those of you in recovery doing this work, please take care of yourselves. I almost bottomed out in the midst of all of this. But in real time, people could call. People do call, and if they're having problems with their insurance, if their insurer is saying we don't cover that, or they need to get plugged into a specialty treatment program, they'd call that number, and they would get someone who would be able to help them resolve those issues. And we did some phenomenal work. We would help people file appeals. We would get on the phone with the insurance companies themselves and sort of help them through red tape. We do outreach and engagement in the communities. And one of the really important things that we were able to do is we were able to harness a network of peers around the state. So after hours and on weekends, we'd be able to get folks connected to someone with lived experience, so that if they couldn't get into that treatment program right then and there, at least they'd have a heart with ears, a person who could stay connected with them, and then help them get connected to a program. And I just put in here Ted's story. Part of the issue too, and when we talk about public health, the silos, even today we do outreach and engagement in the communities. And one of the really important things that we were able to do is we were able to harness a network of peers around the state. So after hours and on weekends, we'd be able to get folks connected to someone with lived experience, so that if they couldn't get into that treatment program right then and there, at least they'd have a heart with ears, a person who could stay connected with them, and then help them get connected to a program. And I just put in here Ted's story. Part of the issue too, and when we talk about public health, the silos, even today with all of, I have yet to meet someone with a substance use disorder who doesn't say, I have underlying anxiety or depression, or PTSD, or bipolar, or any number of other things, right? And so this gentleman, Ted, was having a really hard time getting access to treatment for his alcohol use disorder because he also had schizophrenia. Still, and I don't know, again, how y'all are in New Jersey, but in New York State, there's still a real bifurcated system of care in which, if you've got severe mental health issues, you can't get into an addiction treatment center because there's not a 24/7 psychiatrist on site who can help address some of those concerns, right? So we're doing a lot of work in New York State to help, address those co-occurring issues. But in this particular case, this individual was able to get a hold of somebody who knew about CHAMP, who got a hold of me, and we were able to circumvent some of the barriers and get him access to care. For you policy wonks in the room, I highly recommend going online and looking up if you want to know a little bit more about what we're doing on the parity aspect, on network adequacy, some of the challenges around the insurers. They're very shifty, those insurance companies. I talk about the way in which they engage in shenanigan behavior, where they will do, we'll create a piece of legislation to address something, right, like no prior auth, right, and then they'll figure out how to get around that and do something else. But, they're all God's creatures too. So we're going to continue working with them. But for those of you who are interested in having greater parity, we do have in that report some recommendations. But the bottom line is we've got to take an all-hands-on deck approach. I know we've had some numbness around this, right? We keep talking about this, And I beseech you all, do not become callous. Do not lose hope. Know that for every person that you engage with compassion and tenderness and dignity, that person has the opportunity not just to survive that day, but they get plugged in and they thrive, right? Statistically, I remember when I went to social work school, I went to NYU to do the CASAC and get my training in mental health. And I remember, I started reading about statistically people like me, they don't make it. They do not make it, right? Or at least we don't hear about them, right? Because they tend to be in church basements and they tend to be a little quiet. But I started to get this feeling of survivor guilt. I don't know if anybody in here who's beaten the odds has experienced that. And I went through a little bit of a crisis, where I felt like, why do I get to be here talking about this stuff when so many people haven't made it? And now that doesn't matter, right? Because a lot of us, we do make it. But we need people like you to reach out and pull us in, to look at us with kindness and tenderness. I would say to the insurance companies when I call them up, and I'd have to subjugate that part of myself that wanted to get, and I'd say to them, if this were your mother, or your sister, or your father, or your brother, how would you respond? What would you do? And there would be a change, right? We have to personalize this. It's not just data, although I'm a data freak. I can genie out with the data quite happily. But we have to humanize this. We have to make it real. And so I just want to thank you all for being here. Where's Kendra?
Right there.
Thank you, Kendra. Thank you for all the hard work. I know what it's like to organize these events. And I want to thank all of you for being here and Godspeed in your journey.